Now we're going to hear about Latin America. Raúl?
Well, I would like to thank the organizer for this kind of invitation to present some data from Latin America. I have no personal conflict of interest, but the institution where I'm currently the general director have received some tests for research purposes. This is the content of my talk in these three components. Some words about disease in Latin America. You can see that the survival rates in Latin America arrive where the survival rates in Europe start. And we have heard all the time during several years that we need very good tests, screening tests, organized program. But this morning we were discussing that Europe has no organized program in most of the countries, and they have reduced cervical cancer mortality with no perfect tests such as cervical cytology. So sometimes it seems to me like something like the legend of El Dorado in search of the lost treasure. And in fact, some of the Latin American countries have reduced cervical cancer mortality here in the left. And I would like to call your attention on the case of Chile, which is in the red line. They have been reducing cervical cancer mortality from several years ago, and they are recognized like the country with the most organized or the best organized program in the region. And usually the result of the reduction of cervical cancer mortality is presented as a result of the level of organization in the country. We have also other countries with low cervical rates in the region, but they haven't been able to reduce cervical cancer mortality during the previous years. Another very relevant characteristics in Latin American countries is that the differences between regions within a country. We are the region maybe with the highest disparities around the world, and it is reflected in cervical cancer mortality, where sometimes the differences could be such as high. You see in Colombia, the lowest cervical cancer mortality rates are under 50, but the highest could be close to 500 per 100,000. And it's the same for countries with low cancer mortality, such as Argentina and Chile. We have participated in several studies in Latin America. I would like to present some results from a systematic review we're conducting in collaboration with the Pan American Health Organization, showing the performance of screening tests in Latin America. We reviewed three big databases, and we found about 178 references. And finally, we selected 10 studies to perform the meta-analysis. Here's the evaluation of quality. You see that most of them have some level of bias, but I have to say, to emphasize, those are preliminary results. One of the studies without biases is mine, so it is highly suspicious. That's the reason we're expecting more the reviewers to give their input to this evaluation. And the first results I would like to present is about visual inspection. You see the sensitivity is very low in this meta-analysis. It is about 38%. It is driven basically by two studies in Mexico conducted by GP general practitioners that they found that they obtained very low sensitivity and very high sensitivity. I think the observer in visual inspection influenced in a great manner the results, and the difference with other studies were, in our case in Colombia, we did it with the nurses, and in Brazil, both studies did it with gynecologists. And for conventional cytology, here I present the results using ASCUS as a threshold. We found a sensitivity around 50%. It is the same sensitivity had been reported for conventional cytology all around the world. We were expecting a little bit higher sensitivity given the fact that we were using ASCUS, but anyway, what the same sensitivity has been reported for this kind of test. Regarding liquid-based cytology, the sensitivity was 77%, which is a little bit higher, and it's driven basically by a study in Brazil and Argentina, which found 100% sensitivity, which is, well, it's something strange, and we have to review this data with the authors because they have a previous report on the same study where the sensitivity was lowered for this test. In this meta-analysis, as you see, the performance of the test is similar to the HPV test, but I again say that we need to review those data because there are some inconsistencies between previous reports from the same authors. For HPV test, the overall sensitivity was 83%, and the overall specificity was around 87%. It is a little bit lower than in previous meta-analysis for other regions in the world. yesterday we were discussing how maybe the organization around the molecular tests, such as the HPV test, could influence the performance of the test as well, and it happens in developing countries like in Latin America. Talking about screening progress in Latin America, I have to say that in the review we published some years ago, we found that most of the programs have emphasized on coverage of a screening test. This is the number and the countries evaluating coverage versus the number of studies and countries evaluating quality of screening tests, and the number of studies and countries evaluating follow-up positive screen women. This emphasis in coverage has been driven by the previous results from Europe that have shown a very good correlation between an increased coverage and a reduction in cancer incidence and mortality. But here in Latin America, our data showed that there is no correlation between coverage of cytology and the reduction of cervical cancer mortality. We have the same level of reduction for several countries with different level of coverage. And maybe we misunderstood the message and understanding that only we need doing the cytology but not taking care of other components of the program, as I showed in the previous slide. Trying to find another characteristic of the program that explains the reduction in cancer mortality, I found this data from the relation between adenocarcinoma and squamous cell carcinoma ratio. It is understood that if a screening program is working well, so this rate will increase, and that's the case in Europe. You see the European country has an inverse correlation between a higher ratio between adenocarcinoma and squamous cell carcinoma, but Latin American countries do not have this correlation. And well, the first reason could be the quality of data in both regions of the world, but those data are based on population-based cancer registry, all of them published by the IARC. I suppose that there are good quality data, but I find no correlation between the level or the capacity of the test for detecting the disease and the reduction of cancer mortality. So if there is no correlation between coverage and mortality, and there is no correlation between the capacity of the test for detecting the disease and mortality, which could be the reason for being reducing the mortality in our countries. And the first thing we have to think about is that maybe those countries that are reducing the cervical cancer mortality are improving determinants in terms of socioeconomic conditions, and this influences the reduction of cervical cancer mortality. But it should occur through some pathway. So we developed this model trying to understand the effect of follow-up of positive screen women in cervical cancer mortality. This is the cohort of women based on the natural history of the disease, of course. This is the cohort of women having no screening. In the other extreme is the cohort of women having 100% coverage, 100% follow-up positive screen women. Modeling the differences between coverage and follow-up. Here is the coverage with coverage 50% and follow-up 100%, and coverage 100% and follow-up 50%. We see that the increase in follow-up positive women have a very positive impact on reduction of cervical cancer mortality, which is not surprising because, of course, what is reducing cervical cancer mortality in developed countries is the treatment of precancer lesions, but not only the detection of the precancer lesions. But it seems, as I showed previously, that it is frequently forgotten in the countries in Latin America and in developing countries. Based on this framework, we developed a comprehensive evaluation of cervical cancer screening in Colombia. We did the study in 4 of the states of Colombia, trying to find the association between invasive cancer and history of pap smear. And we found 2 regions of the country having no association between history of pap smear and invasive cancer. You see that here they have a higher false negative rate that maybe is explaining the lack of correlation, and 2 regions having low, having association between invasive cancer and history of pap smear. Those regions correspond to those with a higher percentage of women never screened, a high percentage of losses in follow-up. So those regions of the country were selected to represent different levels of mortality or different levels of the health services development in the country. What we finally conclude from this study, we have at least 2 different settings for developing strategies for cervical cancer control. Some settings, as I mentioned before, with low access to health care, and some settings where the women have regular access to health care. You may see in Latin America, in several regions, they seem to be, you are there, you seem to be in Europe, but some regions seem to be in Africa regarding different levels of the socioeconomic development. So what we think is that we need different strategies to approach the cervical cancer control in these different regions. So we're proposing having screen and treat or screen, triage, and treat strategies in those regions with low access to healthcare, having as usual, screen, diagnose, and treat, or screen, triage, diagnose, and treat, thinking about the high percentage of positivity for HPV testing in these regions. And here are the program characteristics and desirable characteristics of the screening test and the programs components. I intentionally miss here the specificity for triage, and it's regarding the question by Marc Arbyn this morning, thinking that we cannot compromise sensitivity in these settings with the triage in search of high specificity, because we're going to have the same problem we have right now. But we have no perfect characteristics currently with the technologies, but we have to use what we currently have in our hands. And it has a clinical cost, which is the clinical cost for each one of the settings. I would say that for the first setting is over treatment, and for the second setting is over diagnosis. But I have to say that this discussion confuses me, because I frequently hear that over treatment is not acceptable when we're talking about see and treat programs. But frequently, we see women treated for HPV infection in our countries, in my country, and at least in Latin American countries. Let's say not based on an HPV test, but based on a CIN1 result, which is basically the same. So it seems to me that over-treatment is only acceptable if we have a perfect diagnostic test behind it. And if we think this is too much, we have to think, is this too much from the perspective of whom? And what I believe is that over-treatment is too much from the medical perspective, but over-diagnosis is too much from the women's perspective. The women are the ones to have to attend health services very frequently and expose their bodies for a test that is not giving a definitive solution for them. And what about the health systems? Well, I think that it depends on the level of resources and some contextual factors. This is the situation currently in Latin America. Those are the countries that are already using some alternative technologies in national programs. Mexico, Colombia, and Argentina have already introduced HPV tests, and Nicaragua, Colombia, Peru, and Bolivia have already introduced visual inspection as part of the national programs. It could be surprising that Latin America have moved more than Europe, but what I think is that maybe when you feel you're doing right, it is harder to change, and when you feel something is wrong, maybe it's easier to accept new alternative for cervical cancer control. In summary, we may say that Latin America is a region with enormous socioeconomic disparity, as well as significant differences in cervical cancer mortality and health services development among population groups. Despite some countries have reduced cervical cancer mortality, most of them continues to have a considerable burden of the disease without major impact of screening programs. And the performance of screening tests in the region, very careful analysis given specific conditions for their operation. The comprehensive evaluation of screening programs is necessary for a better understanding of the role that new technologies could play to improve disease control in specific scenarios in Latin America. And what I believe there is not only one choice for our countries, that maybe complementary alternative, instead unique approaches, is the best or the most suitable strategy for cervical cancer screening in the region. I would like to acknowledge my colleagues for the help in the systematic review from PAHO and from the Colombian National Cancer Institute. And that's all I have to say. Thank you.